Hello and good day, everyone. You are attending an educational webinar of the International Pediatric Oncology Guidelines and Supportive Care Network, or the iPOG network. My name is Lee Dupuis. I'm one of the co-directors of the iPOG network. In today's webinar, our speakers will describe their experience implementing a guideline-consistent fertility preservation program across multiple sites within the Atlantic provinces of Canada. The subtitle, "One Size Does Not Fit All," already gives us a hint of their experience. We have two speakers today who will tell us more. Our first speaker is Dr. Meghan Pike. Dr. Pike is a pediatric hematologist oncologist at Isaac Walton Killam, or IWK Health, and assistant professor at Dalhousie University in Halifax, Canada. She leads the pediatric solid tumor program at IWK Health and led the IWK team to institute ovarian tissue cryopreservation as a standard of care for prepubertal assigned females at birth. Her research interests include patient-reported outcome measures, fertility preservation, and advancing the care for pediatric patients with sarcoma. Most importantly, she is a mom to her baby girl, Isla, and is a passionate advocate for women in medicine, and I hope healthcare in general, to balance their career and life. Our second speaker is Ms. Carol Digout. Ms. Digout is the Executive Director for the Atlantic Provinces Pediatric Hematology Oncology Network, also APPHON, an organization that helps support the care of children with cancer across the 4 Atlantic provinces in Canada. Part of APPHON's mandate is to locally adapt and implement guidelines. Ms. Digout has a deep interest in evidence-based supportive care and has served on several provincial and national supportive care committees. Carol's main interest now lies in methodology, implementation, and facilitating guideline adherence. As the presentation goes through, please add your questions to the chat, and we'll raise them with the speakers at the end of the presentation. Please welcome Carol and Meghan. Thank you.
Thanks so much, Lee, for that introduction. It's really nice to be here today with all of you to share our experience in Atlantic Canada with oncofertility guidelines. So I'm Meghan Pike. I'm one of the oncologists here at the IWK, and I work with Carol and was involved in adaptation of our fertility preservation guidelines for the Atlantic provinces. So our theme, our subtitle today is "One Size Does Not Fit All," and I think this is the theme of providing care in general for the Atlantic provinces, because although we are one small area on the map, there are large differences between how each province facilitates care provincially, what their needs are, and we have to rise to meet those needs in different ways. So I think we have to be very flexible and adaptable, and this is just one example of how we can do that. So what is oncofertility? So oncofertility is the discussion of the risk of cancer treatments to someone's fertility. It encompasses the need for fertility preservation discussions, or just a discussion of the risk of fertility that patients have demonstrated that they need, both at diagnosis and in follow-up. Providing counseling for young patients with newly diagnosed cancer should always include a discussion of fertility, regardless of risk of infertility. And we have had the chance to review a variety of different published guidelines about how early and repeated discussions about fertility preservation and fertility risk is something that patients ask for and actually improves their outcomes over time. And so our feeling is that every pediatric oncology program in Canada should have pathways for offering fertility preservation to patients that include members of a multidisciplinary team. So we started this project by getting an idea of a baseline, starting with what healthcare providers previously knew or thought they knew about fertility in patients with cancer, both pediatric and adult. So when we asked healthcare providers, many did not know what funding for fertility preservation was available in their province. And many did not know that there was new evidence behind fertility preservation methods like ovarian tissue cryopreservation, which for many years has been considered experimental, but since 2022 has actually been provided as a standard of care at other institutions and no longer experimental. So there was a gap in the knowledge of new evidence there. All healthcare providers felt it was necessary to have educational resources available for providers and for patients. But of course, we always worry about anything we're doing adding more time to an already busy clinical practice. So providers worried about the additional time it would take to provide information and counseling about fertility for patients. And overall, the feeling was that, you know, in medicine, if it's not documented, it's not done in healthcare. So we really felt that we were having these conversations, but maybe weren't documenting them. But actually, our data demonstrated that we feel that we're talking about it more than we actually are. So there was some room to improve.
I'm going to talk a little about our patient and family advisors. We recruited through social media, and we actually ended up with 22 who were on monthly meetings and actually attended 4 weekends to come and help us sort through what needed to be done for them. And their general opinion was that they weren't given enough information. They sometimes felt that they weren't being listened to, or they were being totally dismissed by the oncologists. Cost was a huge barrier in Atlantic Canada. They're being asked to come up with $10,000 to $15,000 on the day they're sent to fertility before any treatment starts, and not many can do that, obviously. They said it's unfair. It causes additional stress for them, as one can understand. And many in our group did not know about what effect their fertility has on their ability to have children, if there is a genetic component. And most of them, they ranged in age from about 12 to 39. And most of them had children or had no idea about if they could have children, if their children could be having cancer. That I did not spell. Okay, how do you? Oh. Okay, so what are they saying? We got great quotes from our patients, which were very sad, actually. We had a 14-year-old girl who said the physicians had no idea how to talk to her about her body, so that's why she joined the project. We had a 17-year-old who said she was extremely sexually active. She was treated in an adult center, and no one ever asked her if she was sexually active, and she was on birth control the whole time through her treatment, and no one knew because she was never asked. Perhaps the saddest one I found was we had a girl who had was told unless she had 3 miscarriages, she could not be referred to a fertility specialist. She did have 3 miscarriages. On the 4th, she did have a successful pregnancy without the fertility specialist, but that was devastating to her. We had a 12-year-old boy who hand wrote 2 pages of notes to us because he looked at all of our educational material to see if they met his needs. He didn't know if he still had chemo in his body. He didn't know if he could get replacement testicles. So, and everyone was shocked when we put up these quotes. People think we're doing a much better job in our discussion. And sometimes the problem is they are told, but they don't remember. We had one mother who secretly taped her oncologist and said she didn't remember, but she went back and she actually did find out they did discuss it, but she had no memory of it. So this just led us to, this was devastating. I cried the whole time when our patients were talking, especially with this little handwritten note from a little boy. So I thought we have to do better and we have to start now. So switch for me. So we knew we had to update the, oh, is this me? Yeah. We knew we had to update the IWK policy and guideline on fertility. Unfortunately, we were almost complete when ASCO, the American Society for Clinical Oncology, came out with their guideline in 2025. We were completely in alignment with it. But because of all the feedback we had from our patients and our healthcare providers, we knew just doing a guideline was not going to be enough. We knew education was not enough on its own and putting a guideline out. This was not our first rodeo at looking at guideline implementation and adherence. We've done it for nausea and vomiting. We've done it for febrile neutropenia. And every time we've done audit and feedback, there has been an increase in guideline adherence, which literally falls off the table after so long, and we need to go back and do it again. So we knew we needed to do this better, and we had to provide more resources than just a guideline based on patients' feedback and our healthcare providers. So Atlantic Canada and APPHON is a little different. We do have 4 provinces. This project, we looked at all pediatrics and young adults, 0 to 39. So we actually had to go into the adult world, which is something we don't typically do. And based on conversations, we knew we needed to include everything for diagnosis and post-treatment. So we are funded by 4 governments. But if you look at Atlantic Canada, we are almost 500,000 square kilometers with only a population of 2.6 million people. Our average number of pediatric cancer patients per year for 4 provinces is only 75, and our average number of 16 to 39-year-old is about 600 to 700. So we have a very low population, thankfully, but we have an extremely large area, and we cross many different governments and funding bodies and health authorities, which makes everything we do a little more complicated. I'm going to throw it over to Meg for a bit.
Yeah, so part of what's complicated is that when we talk about fertility, the fertility preservation services that are available in each province in Atlantic Canada is different. So, we're proud in Nova Scotia to be able to offer all of the available preservation options for pre and post-pubertal assigned females and males at birth. So we do offer oocyte preservation for post-pubertal assigned females at birth. We offer and have done now 2 ovarian tissue cryopreservations for pre-pubertal assigned females at birth. We do offer sperm preservation as well for the post-pubertal males. And then we have the ability to offer testicular tissue cryopreservation for pre-pubertal assigned males at birth or for post-pubertal males who are not able to provide a sperm sample. And that program will be coming in the next few months. In New Brunswick, they are able to offer sperm preservation, same for Newfoundland. And then on PEI, there are no fertility preservation options available. So you can already see the disparities in what's available for fertility preservation as we move across the Atlantic provinces. So with that in mind, we had to adapt our guidelines differently for each province, but we all agreed that it is best practice to discuss fertility preservation and the risk of cancer-directed therapy to one's fertility. Then we also have to adapt things differently for pediatric patients and for adult patients, and thinking about the risk to fertility that happens when you give chemotherapy pre or post puberty. And so what that meant is a series of guidelines. So each province required adult and pediatric guidelines for both assigned males and assigned females at birth available in English and French. So we worked on those guidelines and to satisfy each of those requirements and included a clinical pathway from, patient diagnosis to fertility preservation option in each provincial context. And Carol worked with several working groups to develop this. There were 7 working groups in total from across the Atlantic provinces, and we had representation from every province. These working groups included just over 50 healthcare providers and 22 patient and family advisors. I think you're going to talk about implementation.
Yeah. As I say, we have a long history of doing this. We've been doing guideline audits and adherence since 2011. But as I said, we knew we had to do more for this guideline. It wasn't like febrile neutropenia where it's a hard and fast. We can go into the medical record and they have to be given an antibiotic at a certain time. This was just not as definitive other than the best practice guidelines around referrals and discussions. So we actually had to tailor our guideline implementation to 6 areas, the 2 tertiary pediatric hospitals, the 4 provinces for adults. We started with education sessions with over 600 healthcare providers. We did lunch and learns. We looked at embedding it in their systems where possible. We looked at patient education, satisfaction, surveys, chart audits, pre and post implementation. So we started with a chart audit. So we did 593 charts pre and post, about 280, I think, for 2024 and about 220 for 2025. We looked at, was there a documented screening question or discussion? We did have in our guideline that the Canadian Partnership Against Cancer had come up with a validated screening question. So we had put that in our guideline that cancer treatments could impact their fertility and they'd like to speak with someone about this. We then documented where they were referred. If they weren't referred, was there a reason why they weren't being referred? Like, did they have a vasectomy? Did they not want more children? Was it cost? What the reasons were? Then we looked at, did they do fertility preservation and why or why not? And then we look at the time it took from the referral being sent to being actually seen and having the first consult at the fertility clinic. We know we want their referral and them to be seen and any intervention to be happening pre-initiation of treatments. So we did all of that in our charts. Our pre-guideline audit, most of it was paper-based, so it was not like we could pull out things from an electronic record, which made things tedious, but we did do it. In 2024, across all 6 areas, there was only a 47% rate of guideline discussion documented. Only 16.7% were referred, which shocked me. It was very low. Once they were referred, over 50% actually went through with fertility preservation. So we knew it's really important to get those referrals in. And again, there were reasons documented, but they were very rare to have any sort of documentation as to why or why not. Then we took our traveling roadshow and visited all the hospitals in Atlantic Canada. We did a PEDS data dashboard for each hospital. This is an example of one. So they saw their cancer site, what their diagnosis were, how many males or females they saw, how many documented fertility discussions they had, was there consultation, was there fertility preservation. Then we said why they weren't getting it done. So every hospital had the guideline sent to them. They got to review the guideline. It was put into their hospital system as best practice. They had education, lunch and learns, and as well, they got their own dashboard of data. So that was our pre to see how things turned out. So let's continue on. So we did grand rounds, we visited over 30 hospitals, and as stated, there's probably close to 800, but a lot of people didn't sign in, so our low estimate is around 600 that we went to. And that may not seem a lot, but if you look at our population and for what we are, 600 is a lot because we're not a huge populated area. Okay, this you.
Yeah.
Okay.
So overall, what we determined from this baseline data analysis was that for all patients, a discussion about the risks of fertility and associated standard fertility preservation options are required to have with the patient or family prior to the delivery of cancer-directed or cancer-like therapy, and that should be documented. So when we looked at implementing a guideline, we had to keep in mind that every province and sometimes within different hospitals had different systems of, documenting patient interactions and charting. And so therefore, every center had a different way of implementing our guideline and the questions related to oncofertility. So in PEI, they included the questions on a distress screen. That was a standardized form. The same thing happened with Nova Scotia Health. IWK did not use the same type of distress screener. We switched to a totally different electronic medical record system, OPOR, in December. And so at that time, we decided to build in an auto text question that included whether or not fertility was discussed. In Newfoundland, they went electronic in April 2025 and included mandatory questions on their consultation for patients. And that actually was like a thing that you had to fill out in order to complete the rest of the chart, which was great. And then in New Brunswick, they will be going electronic soon. So they're working on including screening questions, including oncofertility. Right now, they are still paper-based. And so when we looked at the data in terms of who is more or less likely to have these discussions about fertility, we found that age, sex, diagnosis, and the place of care were all associated with whether or not a fertility discussion was held. So female patients and older patients were statistically significantly more likely to have a documented discussion. And then patients with breast, cervical cancers, and sarcomas were more likely to have a discussion about fertility than those with lung or gastrointestinal cancers. And overall, when we look at how documentation improved pre and post guideline implementation, it improved in all jurisdictions within a year, but only statistically significantly improved for 2 jurisdictions.
And I'm going to show an example. There are 2 provinces that did very similar in terms of their distress screen. One had a significant increase in documented fertility discussions, and one did not. So this first one, they put it on their distress screen, and they actually used the CPAC validated question at the bottom. Some cancer treatments may impact. I'd like to hear more information. Yes or no. So theirs went from about 50% to 100%. People were checking that off. It's been documented, and they've had multiple documented discussions. So theirs worked brilliantly. If you go to the next one, who also put it on a distress screen, they, on the top of their distress screen with the ESAS, have a patient comes first, and it's practical concerns related to your illness. The way they included fertility was not the validated question. They just put ability to have children. They had no significant increase in their discussions or people wanting to have a discussion. Twofold. First of all, their screen is not used routinely. So they put it somewhere where it was not going to be effective because only about 10% probably complete the screen, because that is an issue within the system there. The other, it's 100% screen on diagnosis. So they should have had more, and they did. And they also used a validated prompt. So that was the main difference. The other one, and I don't have an example of how they did it because it's kind of interesting. This province had a huge significant difference as well. But within their guideline, they actually put that every person with a cancer diagnosis, regardless of risk, should be referred to a fertility. So it's automated in their system. They have to do it. So, of course, their documented discussions had a huge increase. So those that use their own system, that only had audit and feedback, that only had education, that had like little tick box and didn't make any changes other than the guideline, had slight but not significant increases in adherence. Referrals to fertility clinics. We are really happy with this. Nationally, they sort of came out with a benchmark that everyone should be referred to a fertility clinic within 30 days of diagnosis, and then be seen and have their referral within 30 days of the referral going into the clinic. In Atlantic Canada, your average wait time is only 2.38 days. So once you get the referral into the clinic, you are seen almost immediately, and 94% are seen within 1 week. So going forward, we probably will not audit that very much. We know it's probably as good as it's going to be, but it is interesting that we are hitting it consistently with no intervention or anything being done on her part. Still me, I think. Still me. Okay. So we knew we had to do something for our patients to help them advocate as well and to give them information about what they know and what they need to know about their disease, what questions they should ask about their fertility, and post what they should be doing post-treatment. So we've done an English video, we've done French, Arabic, and Mi'kmaq videos that will all be on YouTube. They're very short, they're 3 minutes, and it answers a lot of the questions they had that aren't included in our medical guideline, but that they want to know. We've also done funding brochures. So we did one for all 4 provinces. The funding changes so frequently. One province did 3 changes in their funding over the 2 years, which meant going back 3 times to redo their funding brochure, get it translated and get it printed. So we are taking that on for all 4 provinces, and the physicians and healthcare providers can't keep up with the changes. So this way they have something that's they can give to their patients who need the information. Oh, this is still me.
This is you. You're just
Skip them. Okay. So what we're going to do from APPHON, and this is sort of what we tend to try and always do. We will take over all the oncofertility educational material, all the updates in Atlantic Canada. It won't be up to each district and 6 people trying to use best evidence and update the guidelines. We will do that for everyone. We'll put it on our website. We're going to take over updating all the funding information so that that piece will be taken care of as well. And we are going to be doing all the statistics and ongoing key quality indicators on guideline adherence for all 4 provinces as well.
And so when we look at how we will, sustain and continue to improve our processes and guideline implementation moving forward, I think one benefit of an EMR is putting in auto text or key phrases that are embedded in consultation forms to prompt providers to remember not only to have the conversation, but to document their conversations and their adherence to the guideline. We are going to continue to track how many fertility referrals are sent and the time from referral to consult. But as Carol said, we actually are meeting guideposts and goals for that time to consult. We are going to be doing patient satisfaction surveys and recruiting for those via posters in various waiting rooms. And we will include questions about reasons for pursuing or not pursuing preservation. And then one of the main things that we've been able to implement at the IWK, which has improved, we haven't measured this yet, but I think has improved our ability to have these conversations on a timely basis, is we have now a nurse practitioner who's leading oncofertility consults, and she aims to do a consult for high-risk patients within 48 hours of diagnoses. She's also the nurse practitioner who does our short-term follow-up for the patients in the first 5 years post end of treatment, and has been having those conversations regularly in our follow-up clinic for survivors. Patient-reported outcomes, we will develop a satisfaction questionnaire. We can embed it with other patient hospital surveys and recruit these patients via posters, and this is something we do in coordination with APPHON to get objective feedback from our patients about whether or not our guideline implementation is having a difference. So like any study, like any data, there's always limitations to what we collect and present. So I think one of the biggest challenges in doing an interprovincial study is that every center has a different system for charting and retrieving information. So it's possible that data could be missed if we didn't necessarily know where to look. We are relying wholly on documentation by healthcare providers. And so it's possible that conversations about fertility were had, but were not documented in the way we were looking for them, or not documented at all. Cancer registries were not necessarily current for all lists, so there may be patients that we did not include in this analysis if we didn't know to look for them. And during the time of data collection, 2 provinces were undergoing a transition to electronic health records. We know that's a vulnerable time for things to get missed or for documentation to maybe be not quite as accurate as providers adapt to a new system. And Carol said it's not as clear cut and dry as it is for febrile neutropenia, when we can chart the number of times a patient has neutropenia. This is a more subjective outcome measure, and the outcome measure is tricky to determine. And this is the same for all guideline implementation work for oncofertility. Is what do we measure? Do we measure time to the initial discussion? Do we measure time to referral, times to fertility consultation? Because really, what is our measure of success? And so we're still working on defining what that means. And maybe it's that we look at all of those outcome measures and see where we can make the most improvements. So yeah, there. Are we missing some slides? Good. That's all I had. And
yeah, we are missing some slides and I'm not sure why. I just want to talk a little about our quality indicators, like she said.
oh yeah,
We will be measuring, all of the times that she has said. Right now, we currently are measuring when they were diagnosed, when there was a documented discussion, when treatment started, when they were referred. And I personally am looking at success by the number of referrals to the fertility clinic. And I'd like to see a few more people opting to have fertility preservation. The fact that we have so many young males that aren't doing it, and I think it's cost-based, is very discouraging to me. So we are going to try and do that as well. In terms of thank you, this project was actually funded by the Canadian Partnership Against Cancer. Our PFAs were absolutely amazing. Our young ones in particular were so vocal and would come and say, we hate everything you do, and we love that. Our navigators we hired in our 4 departments of health. And I just want to say, I probably have done 10,000 chart reviews on guideline adherence in the past 5 to 10 years in the while, and education and doing a guideline is not enough. It will not sustain. Audit and feedback will help, but it has to be repeated. And the only way is to actually embed the changes within your system where possible and to monitor and make sure it's being done. And that's us, Lee.
Well, that's terrific. Thank you both very much for really an engaging and informative presentation. A reminder to the audience, please put your questions in the chat or the Q&A, and we'll take them up. I have a couple questions, if you don't mind. Would you care, might be a bit tricky, but would you care to comment on the differences in the culture or the values in the 2 centers that added fertility as an item on their screening questionnaire? It's strikingly different.
Strikingly different. And one, I think, is a smaller hospital and a smaller health authority that did not have the layers, and they were not undergoing a switch to electronic. We are pushing extremely hard in the one that used it just on the Canadian problem checklist, where they circled it and telling them it's not enough. And we are hoping they will change it in their updated system. But the bigger the health authority, the bigger the people, the more hurdles they are. And I think that was a quick, let's get this done for the project. And I'm hoping it will improve, and they'll go to the validated question now that we have proof that it does work. I mean, the validated question is validated for a reason.
Yeah, thank you. A question from Katrina Mowbray. What kind of financial support do you have for tissue storage?
So the storage is an issue. So for males, they have to come up within themselves. We do have something called the Power of Hope. And we have government support, but often it doesn't. For the 4 provinces, it varies. New Brunswick is currently 20,000, they'll support anything. So travel, whatever. Some of our provinces where you have to travel, and some of them you have to fly. It's not like if you live in Newfoundland and Labrador, you are very far away from a center. There's a lot of them do not cover travel, and most programs, except for I think one, do not cover the storage. But the female